Welcome viewers to my YouTube channel of Sister Dr. Juliet Wangui Macharia. And today is a special day for all students who are at Kenya Medical Training Colleges, and they happen to have done reproductive health. And these students normally come to the wards, especially obstetric and gynecological wards. And sometimes when we examine them, we find them when they do their clerkship, they normally mix up things. So the history of any patient will give you 70% of what your patient is suffering from. So a good history will give us the right diagnosis. A bad history will give us a bad diagnosis. And that's why today we want to just have a summarized clerkship whereby the students who normally see the patients and they are trying to learn how to take proper history taking and also proper examination may understand, and they may have a clue on how also to pass their exams. Because any examiner will be interested in a history which is flowing. Just by listening to your history, he or she is able to come up with a diagnosis. And obstetric and gynecology deals with facts. So, the way you take your history, the fact will be there, and the diagnosis will be there. So, the right diagnosis will give us the right management of your patient. So, anytime the patient walks into the clinic, or anytime you encounter the patient in any of gynecological ward, or maternity ward, or even labor ward, there are things that you have to ask in this patient. And the first and foremost is the name of the patient. So remember, take a full name. When you talk of full name, it is not one name, it is not two names, it is three names. So once you have the three names, this will identify your patient. So the first thing, you introduce yourself to the patient. Who are you and what do you really want, so that the rapport between you and the patient may be there. The patient may get to understand this is not a stranger. This is a doctor. This is an intern doctor. This is a student who wishes to know about my history with the aim of helping me. So we don't just go to the patient. So the first thing, introduce yourself. The second thing, tell the patient why you are there. The third thing, make sure the patient has trust in you. And how will the patient develop that trust? It is how you get to teach her or examine her or ask her the questions. That will make this patient to be interested in listening, to be interested in sharing her story to you. So, after identifying yourself, get the name of the patient. Let the patient tell you who she is. But insist of the three names. And again, note the date and the time you are talking to this patient. Most of the time, when you look at the clerkship, they do not have the date, they don't have time. And this is very bad because you don't even recall what particular date you saw this patient. What time was it exactly? So, the name of the patient, date and time. Those are very important. But for example, any woman who comes to the ward, there is a reason why she left home and came to the ward. So, another thing that you need to know about this patient, where does she live? Was she referred or she has referred herself to the facility? And how old is your patient? So there must be a flow of all this. Identify the name. This is so and so and so. The name, then the age of this patient, Of course, in gynecological and obstetric, we most deal with the female, but sometimes we also have male. So is she a female or she's a male? Then this patient has come to you, maybe she's gravid. So any woman you find at maternity ward, in labor ward, tell us the gravidity of that patient, the parity of that patient. So that is very important, because when you tell us, for example, this woman is gravida 5, para 4, living 0, already we have a diagnosis. This is a woman with bad obstetric history. Or you tell us this is a woman with gravida 5, para 0, plus 4. Already we know this patient has recurrent pregnancy loss. So the gravidity is very important, and the parity of that patient. So always remember that. But another very important thing, note the last normal monthly period of this patient. This most of the time when you meet the gynecological, when you are in the gynecological ward, get to understand when was her last normal monthly period. We have last monthly period, but we also have last normal monthly period. A woman at gynecological ward in the reproductive age who cannot recall when was her last normal monthly period, already you have a diagnosis. A woman who tells you for many years or for many months, I do not even see my menses, then already you start asking yourself, what could this patient be suffering from? So that is also very important. So these are very, we call them particulars of the patient, but they are very, very important. Now, when you are dealing with the patient in labor ward or maternity, you have to ask the gestation age of this patient. So if she talks of 12 weeks, then this will find her at gynecological ward. But when she comes maybe above 28 weeks, she is maternity ward. She has a history of vaginal bleeding. Already you have your diagnosis. She comes to you at 40 weeks, and this woman has lower abdominal pain radiating to the back. Already you have your diagnosis. So these are very simple things, but they have a lot of importance when taking your history, especially in that part of the particulars of the patient, because it will help you now know where you are going to narrow. But another important thing is to know the chief complaint. What was the chief complaint of this patient? What made her to leave home and come to the ward? What made her to be there? So most of the students, sometimes you make a lot of mistake, because the patient tells you, I am here because I have lower abdominal pain. But because you see her with a child, you want now to formalize your own history, to tell us more about how it happened that she has a baby. Yes, it is part of the history taking. But as you are clerking this patient, what is the patient complaining of? So there are two ways to approach this. You may approach from what the patient has been complaining, and this is the most important, the one which we like, because the patient will tell you, I have low abdominal pain. But if she tells you that she has undergone or she had cesarean section done yesterday, already we know the low abdominal pain is due to the surgery. But if she doesn't have surgery, then you have to dig more. So understanding the chief complaint of the patient is very key. For how long has been suffering from? Is it 2 days, 1 day, hours? Write that in your history. Then it comes the history of presenting illness, what we call HPI. This is very important. And this is where now we get to know is this a student really understand the natural history of what the patient has? Because if you do not know the natural history of labor, you don't know the natural history of maybe preeclampsia, you don't know the natural history of antepartum hemorrhage, then it will be very difficult for you to write a proper history of presenting illness. So you have to tell us, how long has this been the problem, the chief complaint of the patient? How long has it been? Any associating factors with all this? Is it what is aggravating this and what is not aggravating the problem? But as you are doing this, the associating factors, you have to understand the natural history. You cannot now tell us because the woman has low abdominal pain and this complete list is labor, then you don't talk of associating factors. Associating factors of low abdominal pain and the woman before you is gravid. What are they? You have to ask yourself. She has a low abdominal pain radiating to the back. Does she have any history of infection? Does he have any history of trauma? Does she have any history of maybe if it's a preterm, does she has a history of preterm labor and all this? So unless you understand, which we are going now to learn in our coming videos, each complication in obstetrics, then you'll get to write a very good history of presenting illness. Remember, a good student will listen to the patient. No matter, sometimes you look at the time and say, I have to finish within 5 minutes. But the moment you listen to the patient and whatever she tells you stick in your mind, it is not all what you write, that is what you are going to present to the examiner. Some of the information are behind your back and you are able to tell them exactly what the patient is undergoing. So this is very important key. It carries nearly 70% of the diagnosis of the patient. Now, after that, you want also to find there's any past history of this patient. That is why I was trying to, if the patient complained of bad obstetric history, which you picked from the gravidity and the parity. If the patient has recurrent pregnancy loss, which again you picked up there, then when it comes to history, past history, you are able to ask, even at the history of presenting illness, you can easily chip in, because that one will help you to understand more about the right diagnosis the patient has. So the past history, you have to know, does this patient has history of surgery and why those surgeries were, what happened, and all these are very important. Because if she has previous surgeries and you are preparing this patient, maybe this patient will end up going for surgeries or cesarean section, then already your mind is preparing, I'm going maybe to encounter visions. This surgery may be difficult in one way or another. So it's very important to look at the past history of this patient. But a very, very important history is the obstetric history of the patient. Here we always want to hear, if this woman has 3 children at home, tell us a summary of each and every baby, of each and every child. When the baby, then is she a male or a female? The year that this child was born. Did the mother encounter any complications? Did she deliver normally, spontaneous vaginal delivery, or did she undergo cesarean section? And what was the reason of cesarean section? What was the weight of the baby? If the mother can recall, most mothers are very smart. They know the weight of their baby and they are able to. Did she encounter any complications? Their mother will tell you, when I was trying to push my baby, the head could not come out. But thanks be to the nurses, they were able to deliver my baby. And this baby was 4.5. Already you have a diagnosis of shoulder dystocia in previous. So this one will also help you when you examine the patient to find out, is the patient having another big baby? which we don't want her now to try labor. We will explain to her and take her to cesarean section, because already she has a history of shoulder dystocia in previous delivery. So understand each and every child. This is very important, my student, and you have to know how do you ask them. Even if she has 8 children, tell us about the 8 children. So in gynecological history, we also wish to know a woman with recurrent pregnancy loss, a woman with history, maybe she had a history of infertility, a woman who has history of maybe vaginal bleeding now and then, and she's pregnant. We must ask about the gynecological history. What about her? Has she undergone any screening? That is very, very important. Does she have any gynecological disorders? Did she have any menstrual disorders? How was her menstrual patterns? How were they bleeding? For example, if a woman comes to you with the low HB, she comes with the low HB, that is anemia and pregnant. And from the obstetric history, you understand, last year she gave birth, and now this year she's again pregnant. There is a lot of depletion of iron in this woman. She did not give her body time to create or to produce or to have those iron which was lost back. So because of that, she's suffering this anemia because there was no proper spacing between the previous child and this one. But again, if you ask about her menstrual cycle, and she tells you that she has been bleeding excessively, she has been having very heavy bleeding for more than 10 days. Every cycle she has to bleed, she has to change, she has heavy bleeding. Again, you know that this woman, because of excessive bleeding, and then she got pregnant before we corrected that anemia. You go to her ANC book, you find that when she reported in her first clinic, the HB was 8. So she carried the pregnant when she's anemic. And that's why she's here with you, because so in your history, the gynecological history has to all this obstetric history, gynecological history. You have, or they have to move, or they have to be at par with the history of presenting illness. Any positive in gynecological history, any positive in obstetric history has to remind you, and that one you have to report during your presentation. It's very important. So you note the positive in gynecological, positive obstetric, and now you try to put them together in the chief complaint. And this one makes your examiner very happy, because you look at the student and you know this student understands what he or she is doing, and she's a good doctor. Now, you also need to find more about the medication this patient has been. For example, the mother tells you, since I carried my pregnant, I have been taking medication because every time my pregnancy, I was diagnosed with a threatened abortion. So I have been put on progesterone to maintain this pregnant. Oh, then that one clicks something behind your back. Then this patient tells you, I have been taking these antihypertensive drugs because I have high blood pressure. Then already the mother may not understand if this is preeclampsia or whatever, but already you have a clue. She might have presented with a lower abdominal pain in your chief complaint. But when you are trying to dig deeper and deeper, you find that this mother is using antihypertensive drugs. She's on methyl-dopa. She has aspirin. Then this is a very important information which should be taken back to the chief complaint, because the mother might not be present with low abdominal pain. The low abdominal pain may be because she's in labor, but having a history of preeclampsia is very important to you as a student, because when this mother is trying to push Remember, the blood pressure normally increases. So you have to know, you have to report this, that this patient, despite of the complaint, she has some issues of preeclampsia. And this is very key to the student. So look at any allergy. If she has any allergy with the drugs or what, just ask about it. But social history and family history is very, very important also. In a woman who comes from a family with history of diabetes, with history of hypertension, with history of recurrent pregnancy, with history of infertility, those are very important things to mention. If the husband takes tobacco, if the husband takes alcohol, if she cannot eat, you look at her, even the nutrition-wise, this is a woman, she's gravid. But when you look at her, she's just cachestic, she's thin. Then that will tell you about the social or family history about this patient. So it's always good to dig more and more about this. Now, you also need to understand where this patient is coming from. The next of kin, the husband we can call, or the partner. Yeah, remember, it's also good to ask about if she had. Yeah, we normally ask about partners, especially in the gynecological history. So if she's not married, but she has partners. A woman who has partners more than 6 in the past 2 years. This, and then when you ask her about the screening or cervical screening, she hasn't done. Then already, oh, this woman has a risk of human papillomavirus. So those are very minor things we can talk, but they are very, very important. Now, after taking this, history, the history presenting illness, obstetric history, gynecological history, past medical history, any history of social and family history. Now, in your mind, as a student, you must have an impression. This is my patient. After clocking this patient, what is the impression here? So, after those histories, we normally come with the first summary. And the first summary has to have all the positives. It is very short. It's a summary of maybe 2 to 3 lines, but full of positives and some important positive and important negatives. Very, very important. After that now, you start now examining a patient. I always tell my students, a good doctor will always lay her hands or his hands on the patient. It is very important. Most of students, most of doctors, sometimes we do not want to touch the patient. Yeah, we do not want to listen to the chest using the stethoscope. Remember, even your hand on your patient is a healing. It's healing on its nature. By nature, it's a healing. Yeah, you put your hand on your patient. The patient feels you. You feel your patient. There is that connection between the doctor and the patient. Yeah, you touch the pulse, you put the cuff around her hand, you touch her abdomen. Those are ways the doctor communicates with the patient. But most of our students, we run from our patient. We don't want to touch them. We think that we are going to, I don't know, whatever. But let us learn to touch our patient. Unless there are things that makes you not to touch her. Okay. When it comes to examination, we start with the general examination. And when I examine some of my students, they miss up. When I tell one, just do a general examination of this patient. Yeah, so some will tell me, you just see a student going to take a blood pressure machine. Yeah, some will take a temperature, some will try to. When you talk of general examination, the first thing, listen, you have just finished taking history. You were discussing with your patient. Now, what you need is a general examination. A good student, as you were taking your history, because you have to be very fast, especially when you're in an exam. And you also need to I always tell my students, scan your patient head to toe. Scan as you are talking, just scan, because there is part of examination and you'll have picked this. So we normally do general examination from head to toe. How is the hair? How is the texture of the hair? Is this patient anemic? Is this patient on oxygen? How is she breathing? Is she in distress? So those are very important things that which you can see in your patient. You don't need to examine, you just need to see. So you are doing a general examination, so you can see your patient has difficulty in breathing. You can see your patient has got oxygen. You can see your patient has a cannula, has a catheter. This all has to appear. Why does your patient has a catheter while the next patient does not have a catheter? So you have to report this. And when you report about the catheter, you tell us if it is draining urine and how much urine is there. What is the output? If it doesn't have, is the patient producing urine or not? Because if it's a patient who has got hypertensive disease like preeclampsia syndrome, and if she has oliguria, already we have a very big question about her kidneys, the severity of the disease. So the catheter itself has a clue of what this patient might be undergoing. So another clue is the cannula. You look at the cannula, you look at what is there. What kind of medication? You find this magnesium sulfate. This patient, magnesium sulfate, she told me she has hypertension. You need to ask if the patient can recall for how long has this medication been flowing. Then you find the patient, already you have your diagnosis. You see? So these are very important things that you pick. If the patient has a difficulty in breathing, you see that she's trying, she's being helped with the oxygen. Already, SpO2 for you is very important. So the pulse oximetry has to be in your pocket to check this. And so on and so on. So after doing your general examination, now you report about the vitals of the patient, the temperature, the oxygen, the temperature, the pulse rate and all this. And again, those one can tell you. But when you are doing the general examination, remember we talk of the pallor. Remember, we talk of the jaundice, we talk of the edema, we talk of the dehydration. So when you are talking to a patient, especially if it's a diabetic mother, whether in the maternity ward or gynecological, you listen at the breath, will tell you, is the patient who has been dehydrated, a patient who had a prolonged labor, a patient who had obstructed labor. You are in labor and you can see all this. You have to report that. So remember, and I'm going to repeat this, that you cannot have a proper history if you don't know the natural history of the disease. So from there, you go to now to system-wise. We have respiratory system, you have the cardiovascular system, you go to abdominal system, now this is if she's gravid, remember you must now examine this patient. You shall be looking at how do we examine a gravid woman. And what do we normally check in a gravid woman? So this is very important. We are going to talk more about that with some diagram that will help us show how we normally do, especially using the leopard maneuver, which is the how do we start. Because when I tell my student, can you do a leopard maneuver? You find somebody starting from lateral, some going to pelvic. Now, we have to know it has to be system-wise. But remember, it's always good also, although sometimes it's difficult. If a woman, you find that a woman is jaundice, a woman has got a liver disease, it's also good to try to see if you can palpate the liver, in spite of the gravity that she has. Yeah, it's always, so the history you have taken will always direct you to where you should emphasize your examination. So that is very important. And as you check the abdomen, if the woman has a tender abdomen, know where this tenderness is coming from, what has happened. If she's gravid, and then you touch here is tender, you touch the other side is tender, the fundus is tender, the pelvic part is tender, then you ask yourself, is this patient suffering from placenta abruption? Does she has any pervaginal bleeding which is not normal? And is she in labor? All this you have to ask. she's in labor, she has contractions, she has very tender abdomen, then your diagnosis must start changing and you think of placenta abruption. Yeah, and that one will help you now to ask for more. So understanding what your patient is presenting is very, very important. So after doing your examination, you are going to look more about this when we are dealing with a gynecological patient and when we are dealing with a gravid mother. So that one will be explained in the coming videos. But again, remember, and you should know that after this, now you give us the second summary. Now the second summary has part of the first summary plus now any examination part that you feel that you have to report. And if she's gravid, you have to report how is the lie, how is the presenting of the baby, and all this. If she has twins, how is all this? You have to tell us. Then after that, now, because you have cracked your patient, you need now to tell us what are you planning? What is the management of this patient after your diagnosis? So again, you cannot just tell us you go and deliver this mother. A mother with very high blood pressure, we call it, maybe she has impending eclampsia. Yeah, then you tell us the only thing I can do here is just to go and deliver. Yes, delivering is important in this mother, but what is the first thing that you have to do? You have just encountered a patient who had a PPH, postpartum hemorrhage. What was your first? If I tell us all this. So remember my words. You cannot give us the proper history of this patient if you don't know the natural history of the disease. Then after that, you have to tell us any investigations that you are going to do. And all this will be led by proper history taking, all the way from the particulars, history of presenting illness, the obstetric history, the gynecological history, family and social history, the first summary, the second summary after proper examination, and now we have the right diagnosis and the proper management of this patient. But you will never learn this in books. My dear student, most of you waste a lot of time. We are not wasting. We want to gain knowledge. But we are more in books rather than being in words. I always tell my students, the best books, the best gynecological books, the best obstetric books are in the words. You go in the words, you find there is a PPH patient. You find there is a preeclampsia patient. You find there is a patient with the premature rupture of membrane. These are 3 topics already. You get these 3 topics, you go and read, you know how to take history about them, you read about it, you understand the natural history of this disease. Tomorrow you come again, you take another book, and now from what you have seen and what you have cracked, now go back now to the books, learn what has been discussed, what has been researched, and then you become a very good doctor, you become a very big clinician, and people will wonder, what type of a student is this? He's doing so well. So, learn from the books in the words, then crack these books. After that, now go to the real books. But remember, the best books are always in the words. So as you listen to this, please don't forget to subscribe to my YouTube and continue following me. Next time we shall be talking about the menstrual cycle patterns, and this is very important because it lays most of the diseases in women, especially in the gynecological department. So join me in my next video and learn more. Please don't forget to subscribe to my YouTube. I am Sister Dr. Juliet Wangwe Macharia, and may God bless us all. Thank you.